A picture was shown of a young man who has oral and conjunctival ulceration with few blisters on the trunk. So he developed the above lesions 3 days after consuming herbal concussion. So the first question says what are the differentials? The B part says if the lesions cover less than 10% of the body surface, what is your final diagnosis? Say in what ethnic groups is the disease common? Mention two infectious causes and two pharmacological causes. What signs can be elicited on the lesions and how will you manage? So I'll attempt the question one by one. So I got a similar picture from the net. So we could see the oral ulcerations, and if you look at the left side, we'll see ulcer there and those skin lesions. So what are my differentials? So my differentials are one, Steven Johnson syndrome. Two is toxic epidermal necrolysis. The third one I consider is the erythema multiformis, and the fourth one I consider is staphylococcus scarlet skin syndrome. So the said if the lesions cover less than 10% of the body surface area, what is the final diagnosis? Because less than 10%, so final diagnosis will be Steven Johnson syndrome. So in what ethnic groups is disease common? Found out Black and Asian ethnic groups common in them. They mention two infectious causes and two pharmacological causes. For the infectious causes, consider herpes simplex virus, mycoplasma, pneumonia, while two pharmacological causes, sulfamethoxazole and carbamazepine. Then what signs can be elicited on the lesion? So you can elicit the Minkowski sign and the Houseboat-Hunting sign. Then how will you manage? Because the management pressure, so you take a short history to identify the offending agent and the drug. So you also want to do a quick examination to identify the extent of the body surface area affected and also assess the degree of mucosal involvement. So and the treatment profile will be number one is to discontinue the offending agent or the drug, which you have identified from the history. Then the mainstay of treatment is supportive care, which includes fluid electrolyte and temperature management. So the estimated requirement is of 2 meals package of the body surface area involvement in the first 24 hours that you can subsequently titrate to achieve a urine output of 0.5 to 1 meals per kg per hour. Then you want to maintain the temperature of 30 to 32 degrees to reduce the excessive caloric expenditure. Then the other point thing you want to do is the pain control, which is based on the pain intensity. You can use a scale of 0 to 10. So divide into mild, moderate, severe. That's if the pain is mild, you can use non-opioid like paracetamol. But if it's being moderate and severe, you can employ use of opioid. Those are rapid onset action. Then nutritional support too is very important, especially in the anabolic and recovery phase. So you want to give about 25 to 30 kilocalories per day. And infection control too. So you sterile handling the isolation nursing care. Then occasionally, while patient is on admission, you want to run some culture, especially when you know that patient has started showing some clinical signs of infection. So the wound care part, so it just omitted the wound care, which is very important patient. So I'll just take a general overview, follow this outline. So Steven Johnson syndrome and 10 have severe cutaneous adverse reactions, which are characterized by excessive necrosis and attachment of the epidermis. So the mucous membranes are affected in more than 90% of patients and usually involve at more than two distinct sites that the mucosal involvement. And the classification is actually based on the body surface area affected. So if the percentage body surface area affected is less than 10%, you term that Stevie Johnson syndrome. And if it's between 10 to 30% is the Stevie Johnson 10 overlap. And why if it's greater than 30% of the body surface area attached, so call it 10. And generally, the word epidermal nephrolysis has been used to refer to those theory classifications. So it's now varied and varied based on the percentage of body surface area affected. So epidemiology wise, there's about 2,000 per million people affected each year. And the Stevie Johnson syndrome is actually commoner than the 10. And yeah, so and it's common in females and older people. So the risk factors associated with the this include of the the risk is also higher in patients with malignancy, older adults, the ethnicity, early blacks, and the Asian groups. Then other factors also that might put the patient at risk if the dosage of the drug use is actually on the high side, so the patient with impaired renal function that could affect the clearance of the drug. So the etiology can actually be infectious, drug-induced, malignancy related, and sometimes about 25 to 30% to be idiopathic. So these are the infectious agents to be viral, bacterial. The common viral ones are the HSV, AIDS, virus, influenza, and the likes. The bacterial, the plasma pneumonia has to be indicated. So for the drug-induced, the the table just shows the various classifications of drugs from the from anticonvulsants such as lamotrigine, carbamazepine, phenytoin, the other groups which we can actually go through when we get slides. So for the pathogenesis, basically SJS are actually predominantly a drug specificity T-cell mediated reaction. So what usually happens is people that are predisposed to are genetically predisposed, those with the HLA T-cell receptor. So when they are exposed to any of the offending drugs or agents, so this binds to the T-cell receptors, which leads to the elaboration of the CD8 T lymphocytes with subsequent release of cytotoxic proteins that now result into the clinical features we see in patients with SJS. So the summary is just that okay, patient that is genetically predisposed to it, now exposed to the drug, which serve as the antigen, binds to the T cell receptors and release of the cytokines. So this is just to summarize what I just explained. So for the clinical presentation, for the clinical presentation, for the for the clinical presentation, so the prodromal symptoms could be fever, malaise, features of upper respiratory tract infection. So then the cough, rhinitis, sore eyes, and myalgia. The cutaneous mucosal involvement, which would occur 1 to 4 days after the prodrome symptoms, and sometimes they could go concurrently while patient have some of those prodromal symptoms. And it usually start with erythematous thyroid lesions, which could be annular or papillary macules. Then you could have then later generate to the flaccid bullae, then large painful eruptions. And you can actually demonstrate Unicosky's sign, and also note that the mucosal involvement is not just limited to the oral part. So you can have the pharynx, esophagus, GI tract, genitals involved. So when you see patient, evaluate further in this regard. So this just to defeat the various skin manifestation you present with. So you can see the thyroid light, that's my own extreme right there. You see the bullet form that capture the oral mucosal. So there's a severity scoring for this, which basis of the age and some clinical and biochemical parameters able to predict mortality. So a score of 1 gives us a mortality of 0.2, while a score of greater than 5 the mortality of 90%. So diagnosis is basically clinical, so the history, which can support with serological evidence of from skin biopsy. So you always get this of the patient presented with sudden onset of painful mucocutaneous eruptions, which is associated with some systemic symptoms, and there might be a history of exposure to a drug which, like the glucose that was treated, and the patient had a herbal concoction, so you might get that history. And like I said, you can support your diagnosis with histological finding from skin biopsy. And the classical histopathological features include basal keratinocyte apoptosis, full thickness necrosis, and separation of the epidermis at the dermal junctions. Then can also see some mild infiltrate of T lymphocytes. and under the direct fluorescence is always negative. And some other supportive investigations we can do to help the management of this patient. We want to take the blood count, the electrolyte creatinine, the liver function test, and the blood function test might be necessary. And I do some minimal cardiac function evaluation of the patient. And the differentials include the erythema multiformis, encephalomatous drug eruptions. Stress is also a good differential. Then the staphylococcal skin scarred syndrome. So for the management of the patient, most important thing is to, to identify the sorry to identify the offending agent, which you have to discontinue as soon as possible. Then you apply supportive care, which includes fluid electrolyte and temperature management, like I alluded earlier when I was answering the question. Then pain control too is very important. Nutrition support, infection control, and sorry for the wound management. You shouldn't forget that tetanus prophylaxis is very important, especially if the patient has not been vaccinated. The other drugs that have been employed include systemic corticosteroid, some immunosuppressant, though they remain controversial. All right, thank you very much.
Yeah, thank you, Dr. Taiwo, for a wonderful
Yes.
presentation. You kept this time, even though you are on transit. Well
Yes,
done.
thank you.
Well done. So, okay, we welcome contribution, Dr. Tanimu. Tanimu, can you go ahead? Okay, let me look at it.
Am I audible?
Yes, I
Am
am.
I audible?
Yeah, audible. Yeah, you're audible.
Thank you very much. Thank you very much for this presentation. It's a nice one. May God help us all. Apart from the causes, the ones that are idiopathic, sometimes they may be related to genetic causes. There are genetic causes associated with the disease, including HLA-B5102, B1502, HLA-B5801, HLA-A29, HLA-B12, and also females are more predisposed. Additional differentials include bones, trauma, and systemic sclerosis. And for the management, don't forget about the eye care, care of the eyes, including examination by ophthalmological assessment, and also they can have ectropion, all this, they can have even corneal ulcerations. So eye care, eye examination, and care of the eye using artificial eye tests and cleaning and ophthalmological assessment. Even sometimes they can need to have inoculation. So also another part of the management include use of plasma pharesis. And use of plasma pharesis is also employed, as we said, also for the care of the eyes. Thank you very much. But by and large, it's a very nice presentation. Thank you.
Thank you, sir.
Okay, thank you, Dr. Tanimu, for your contribution. Okay, so going to the chat box. Okay, Dr. Success said, thank you for the lucid presentation. Shamsuddin said, temperature of what part of the body will be maintained at 28 to 32 degrees? Thank you for your good presentation. Dr. Aniko said, thank you. Any need for barrier nursing and eye care? Okay, Dr. Tanimu just mentioned the eye care, bonds towards, and also differentials. So I think he mentioned some of those differentials. Okay. So Dr. Shamsuddin is a temperature of what part? I think he means, is it a core temperature or peripheral temperature? So Dr. Taiwo.
Oh, okay. So actually, they call temperature.
Okay. Any other contribution? Any other comment or contribution? Okay, you can share your screen, Dr. Taiwo. Dr. Maji, say what is used for the oral care? Dr. Taiwo, can you hear me?
All right. Okay, so for the oral care, so we have located that you can use mouthwashes and some topical anesthetic agents to minimize pain.
Okay. And I remember ATS prophylaxis and TT immunization. I think he mentioned
Yes.
too. Any other? Contribution? Is Dr. Adibola in class? Dr. Adibola? For Dr. Justice, we just reassigned it yesterday. So we told him that, I told him that he will present on Wednesday. So Dr. Adibola. If he's not in class, do we solve the question as a class? Probably get
the question and answer. Can you hear me?
Hello?
Dr. Akam, can you hear me?
Yes, I can hear you.
Let's share the question and answer it.
Okay. So can someone get us the question to project from Dr. Yaya? Can you project it for us? I will get the volunteer to answer. Dr. Yaya, are you in class?
Yes, sir, I'm in the class.
Okay. So can we
Sorry,
just share the...
Okay, I'm driving. Let me see when I... Chief, sorry, I have some issues now.
Okay.
I'm dropping somebody.
Okay. All right. So let somebody help us. Let me look for the question. Somebody will help us share it. Can somebody help us share it? I think Dr. Christabel has shared it on the group. I think it's question 7.
Sorry, which question is it? So that I can navigate to the notes.
Let me look. I think it's question 7.
Okay.
Yeah, question.
Question 5. Dr. Akam, question 5.
Oh, okay, sorry, question 5. Not 7. No, question 7. I think Dr. Taiwo took question 5.
Okay. Yeah, got yourself on them.
Okay, this project, can somebody help us out with somebody volunteer to? Okay, Dr. Success. Hello, Dr. Success. Can you hear?
Good morning.
Yeah, morning.
Okay, I want to attend the question. Okay, so this is an elderly woman, that's the question, who was wasting unconscious, had microglossia, hypothermia, bradycardia, and of 40 beats per minute. Blood pressure was 90/60 millimeters of mercury. She had periorbital swelling, fetal edema, chest X-ray showing pleural effusion, atelectasis, and the random blood glucose was 4.5 milligram per DL, which is low. The serum sodium was also low. And so the answers, the first, what are your differentials? Okay, so my first differential would be hypothyroidism, considering the fact that this patient had myxedema coma, of course, from hypothyroidism, because this patient has coma, she's unconscious, she's hypothermic, bradycardic, and of course, the blood pressure is also low. She also has periedema, periorbital swelling, and also, of course, fetal edema. So I'll be thinking of myxedema coma. Okay, so okay, my other differentials include Addison's disease. Yeah, so I think of Addison's disease. Then I also think of what's this thing from? Okay, that's what I think of now. Then my most likely diagnosis will be myxedema coma. Then list the factors in the history that support your diagnosis. I think I've defended that already. The serum TSH is 200 per liter, and of course the free T4 is 1 milligram per liter. What's your final diagnosis? So it's in keeping with my final diagnosis of hypothyroidism. So how will you manage this patient? So in managing this patient, I will do my ABC of resuscitation. ABC of resuscitation. This patient is unconscious. So of course, I'll make sure that the airway is patent, established circulation, and patient's breathing so it's also optimized. Then for hypothyroidism, I'm going to give these patients glucocorticoid, maybe hydrocortisone, because this patient's blood pressure is actually reduced, plus the systemic collapse is manifesting. This patient too will benefit from levothyroxine. So usually they ask which will you give first, the steroid or the levothyroxine. Usually said that the cortisol, the steroid is given first, which will actually help this patient before the levothyroxine is given. I'll also monitor this patient's, of course, identify other triggers. Most of the time, their trigger may be infection, or sepsis. So I will also treat. Then this patient has atelectasis, so she will need respiratory support. And then, of course, specialists, other multidisciplinary approach, like pulmonologists and the cardiothoracic surgeons. Then I will also optimize the glucose level, and also I'll manage other electrolyte derangement. I'll monitor input and output charts, Then for this, also make sure that this patient's temperature is optimal. I'll also optimize serial or at least weekly thyroid function tests to also check, progress of this patient's condition, which most likely should improve. So these are my small contributions concerning the question.
Okay, thank you very much, sir, for successful volunteering to contribute. So, other contributions, please.
Yeah, I think I just thought of adrenaline insufficiency as one of the differentials. Thank you.
Okay, all right. Thank you very much, Dr. Tanimo.
Okay, thank you very much for the attempt. And also, you have to evaluate the thyroid gland, neck ultrasound, even neck CT, and also to assess whether it's having, what are the nature of the thyroid? Is it nodular, diffuse, or also extension of the thyroid to because he may have even thyroid carcinoma causing hypothyroidism. So you have to evaluate for that, as she is an elderly woman. So also anti-thyroid globulins, evaluation of the chest, because of the atelectasis may be associated with the tumor of the thyroid extending to the chest. So also evaluation of the chest, she may need even chest CT for further evaluation, and also anti-thyroid globulins assessment in the lab. Also, you have to also, besides that, you have to also say the value of the insulin, the value of the value of the glucose you are given 10%. You have to continue evaluation for the user random blood sugar. You have to also assess for the other endocrine diseases associated with elderly people. And you have to evaluate for the Addison disease. You have to also evaluate for others. But by and large, it's a very good attempt. Thank you very much.
Yeah, thank you, Dr. Tanimo. Any other contributions? Any other contributions, please?
You have to also look for her nutrition because of this hypoglycemia, the care at home, whether there is good care at home and the nutrition status, what her eating modalities, and all that issues.
Okay. And thank you too. Any other contributions? Our endocrine soon to be specialist. Can you make any contribution?
Okay, hello, good day. I'm not an endocrinologist, just an addition. In myxedema coma, that's in hypothyroidism leading to coma, we have like 6 hypos. We have reduced pulse rate, which is bradycardia, hypotension, hypotemia, hypoglycemia, hyponatremia, and the 6th one. So there are like 6 hypos we see in myxedemic coma, which this patient actually has. So I'm just trying to draw our attention back to the 6 hypos we see in coma associated hypothyroidism. So hypothyroidism, hypoglycemia, hyponatremia, hypotemia, hypotension, and reduced pulse, which this patient has. So that's just an addition that I have to this. Then again, too, I don't know whether we can actually go like for a differential, whether we can go with neuroglycopenic coma, although this patient obviously has features suggestive of hypothyroidism, like a differential. Then also, I don't know if we can work with stroke with raised intracranial pressure, just a differential, because in raised intracranial pressure, we have bradycardia, though we normally have systolic hypertension, and then irregular breathing pattern. So, but I'm just thinking whether we can add on to it like neuroglycopenic coma as a differential, though it doesn't meet up with everything, and then coma with stroke with raised intracranial pressure. That's just what I have to add. Thank you.
Yeah, thank you. I think they can go for that as differential. Yeah, she could even have sepsis. She could even have drug overdose. We don't know. It's possible she has. She's an elderly woman, probably with other comorbidities. That could give her multiple medications that she's taking too. So those things too can lead to this too. Okay, let me read the. Okay, Dr. Oladoto said hypopituitarism, Sheehan syndrome is another differentials. So I don't know. Okay, yeah, Sheehan syndrome is another. Then Dr. Ekele say, can anaphylaxis be a differentials too? So it could also be the differentials.
Okay, hello.
Yes.
Yeah, good morning.
Yeah,
okay,
morning.
so I just wanted to add some things to Dr. Success attempt. For the temperature control, patients come with hypothermia. What you want to do is you want to give the patient warm blankets, for passive external warming. You want to avoid placing the patient on active rewarming. Now, those forms of active rewarming, those heaters, fire, you don't want to put them near the fire or heater, something like that, because it may further worsen their condition. They can have vasodilatation and more hypotension. So you just place them on warm blankets. The target is to increase their temperature by about 0.5 degrees per hour, 0.5 degrees, not more than that per hour. You want to also give them warm humidified oxygen because they could have hypoxia. They usually, one of the tests you want to do is the arterial blood gases. They have low partial pressure of oxygen and high PCO2. So you want to give them warm humidified oxygen. Then for the hypothyroidism, correction of the hypothyroidism, like you said earlier, you want to give more of the tests you want to do as you are taking your samples for your thyroid function. You're also taking for cortisol because they tend to have hypocortisolemia. So you want to correct the reduced cortisol by giving glucocorticoids. IV, hydrocortisone is indicated here. In this condition, you want to give hydrocort. Your DEXA may take some time to work, another glucocorticoid, so you want to give your IV hydrocortisone first. Then for the correction of the hypothyroidism, we use IV T4 thyroid hormones. If you don't have an IV access or you don't have the intravenous ones, you want to give it via NG tube. You use about 300 to 500 micrograms start. So you want to give your IV T4, or you give it via your NG tube. Then from the next day, you give 50 to 100 micrograms daily. Then if there's no improvement after 24 to 48 hours, you want to give T3. All these ones, we probably don't have them in our environment, but it's just good for us to know. You want to give IV 10 micrograms of T3 8 hourly. And hopefully patient should improve. One also has to take note the thyroid replacement medications, they are usually affected by malabsorption. If they may not be easily absorbed in the GI for several reasons. By the time you are giving your thyroid replacement and your TSH, because what you use to monitor your patient is you use your TSH. Patient coming with very high TSH, so you are monitoring your TSH for it to go down. But if you find out that your TSH is not going down, you probably have to query malabsorption. Common things that could cause malabsorption: H. pylori infection, another malabsorption, celiac disease, and other things. So you may have to treat for H. pylori also, and treat for any other common cause of malabsorption. Or you have to increase your dose of thyroid replacement to ensure that your TSH goes down. So once your TSH is going down, you know that you are winning. So I think those are just a few things I want to contribute. Thank you.
Thank you, Dr. Victor. Thank you, Dr. Victor. Any other contribution? Okay, Christian, where Boko said pituitary apoplexy is differentials. Okay. Any other contributions, comments?
But sir, I don't think Sheehan syndrome is part of the differential, because Sheehan syndrome is to do with female reproductive age, having abnormal bleeding, then ischemia in the hypothalamus or an associated disease. But I don't think Sheehan syndrome will be part of the differential in this case. But I stand to be corrected.
Yeah, thank you, Dr. Tanimo.
I think maybe the Sheehan's because of the hypopituitarism, they can have a hypothyroidism subsequently, and that could present like that with myxedema, coma. I don't know.
Okay. All right, thank you for your contribution. Sorry. Dr. Iguzozi.
Yes, thank you. Good morning to everyone. Yes, just to make a contribution too, I think Dr. Victor, who spoke before me, said it more or less. Just to add one or two things there. The first thing is that the situation we have in front of us, we can't entertain Sheehan. The reason is, the question is very clear. It says an elderly woman. Sheehan is usually in reproductive age group. So that already knocks out Sheehan. Yes, would have been a good consideration, but for this setting, answering the question, you can't put in Sheehan there. The examiner will say, look at the age of this woman. So it won't fit in there. Pituitary hypoplexy, however, will fit in better than Sheehan. So that's the first point I wanted to make. Then secondly, yes, yeah, concerning the thyroid hormone replacement, yes, like what Dr. Victor said, we should understand that there's the T4 and the T3. Now, there's this debate of whether mono or dual therapy is what you should go for. Mono means just the intravenous T4, or a combination of T4 and T3. There's that debate. So you find out that some authorities will say, you do the two. You do the two. You see some authorities say, do one. So if you see that, then you can always make your argument that there's a place for both of them being administered. Now, then I think one other, another speaker draw our attention to all the hypos that go with myxedema coma. That is very, very important, because in the supportive treatment or the supportive therapy, you are addressing each of those hypos, each of them. So for example, the hyponatremia and the hypotension, which the patient has. So that means IV fluids will have to come in under supportive therapy. The hypoglycemia, which the patient has, that means glucose administration has to come in. You know, the hypothermia, which they usually have, that means rewarming has to come in. But it's good, Dr. Victor pointed out that caveat of it's a passive rewarming. Another way of saying it is a gradual rewarming. That's another way of putting it. So it's not very, very aggressive rewarming, because that causes more harm than good. Then, yes, also part of the supportive treatment is to nurse as a comatose patient, because the question clearly says the patient is brought in unconscious. So you have to nurse as a comatose patient. So that involves frequent turning, you know, prevention of aspiration, as it were, attention to the sphincters, you know, like fecal, either infarction or excretion, urinary retention or urinary, so passing a catheter, frequent changing of, you know, all of that. So nursing generally as an unconscious patient too, very, very important. So all of that, and then of course, ventilatory support. This patient clearly will need ventilatory support. I will strongly believe may require mechanical ventilation, because the question clearly says there's atelectasis. So yeah, so all of that will fall under. So, and then lastly, of course, to treat the precipitating cause. So be it infection or whatever. So all of that supportive treatment, very, very, very important. So aside from glucocorticoid replacement, so usually the principles of treatment are just like in 3. First principle is the thyroid replacement, second, glucocorticoid therapy, and then third, supportive therapy, and then everything which I've said under supportive therapy. Thank you.
Yeah, thank you very much, Dr. Emmanuel, for giving us a summary. Thank you. Dr. Jafar said myxedema coma is a medical emergency. It is the compensated state of severe hypothyroidism. Care here is intensive, requiring a multidisciplinary approach, admitting to ICU, principles of management, ABC, maintain airway, warm oxygen helps their type 2 respiratory failure, IV fluids, warm, correct hypothermia, vasopressors for tissue perfusion, levothyroxine in glucose, monitor cortisol for steroid if indication met, hyponatremia correction. Okay. Identify, precipitants and treat. Okay. So Emmanuel has given us a summary of that. So Dr. Ezekiel said for this specific question, we should be careful with normal saline because patients already has pedal edema, pleural effusion. It is likely may have heart failure, yes. So we have to be careful also with the use of normal saline because heart failure also is one of the precipitants also of myxedema coma. All right, thank you. Any other contributions? Any other contributions? Okay. I think Justice will do his presentation tomorrow because he was just reassigned yesterday. And then I think we'll continue with, yes.
Can the class take it? What's the question about? Because I know we this close to exam, the exam participant should be speaking really. So I think it's something the class can handle. You understand? See what Dr. Success is. By the way, so Dr. Success, congratulations. Dr. Tanimu, congratulations. Yeah, attempted that question. It showed that somehow she have answered that question before. So congratulations, my dear sister.
Dr. Christian, I didn't know your people had stuff like this. Effortless stuff, man. Flowing.
See stuff, see stuff. But you understand? I'm not wondering why Dr. Tani Atta want to move it to the next day when people are moving stuff like this. I know Success only has stopped and Imo always has stopped. She spoke effortlessly. If it was an exam question, she would have passed that station effortlessly. So to me, this is so close to exam. People are hot with information. They are so hot with stuff. Let them release those information now, Dr. Atta. I think the class should just attempt it tomorrow because, once we're done with all the questions, we have a session where we give final talk on the exam itself so that we can still do that before, because 20 something is like 2 weeks, I'll be something like that. I know from next weekend, people should be traveling. From next weekend, people should be traveling. So whatever was
my exam is 20th of this month, next week Wednesday.
You see what I'm saying? You see what I'm saying? But Tata, please let's quickly attempt that question so that we can run through because we want to answer as much infectious disease, as much dermatology question as we can. Because this April, I think dermatologists tend to go into infectious disease. So let's try as much as we can. Because even if you didn't read it and it was discussed in class, if you can remember that basics that was discussed in class, I'm sure it will help. So please let's quickly attempt the question since exam is just looking at us, please. Thank you so much, Dr. Atta. Dr. Success,
Okay,
thank you for pointing out art.
Okay, someone should help us share. Please share the question again. Please, someone should help us share the question again. So I think it is question 8. Okay, so this is question 8. Volunteers. We are up to 19 class. So let someone volunteer, please. We can go through it too on our phone because I think there are different scenarios that we painted. So we can go through it on the phone if you cannot follow on the.
Dr. Atta, is taking longer than necessary for someone to volunteer. Just pick anyone from the class. Pick your friend.
All of them are my friends.
Just pick Rukaya. Rukaya, please. Rookie.
Good morning. Good morning, Chief Okopi. Slight issue is I have a unit presentation at 8, so I might not reach the end of this session. Like I have to switch to our unit presentation. So I don't know if it's a good idea for me to start.
Just start, no problem. Just start.
Okay, so Station 8 says it's a rheumatology station. There are different versions of the question, but let's go through. Version 1 says a man with hypertension of 20 years, presenting with swelling of his toes, sudden onset painful swelling of his right big toe. He was placed on 50 milligrams of hydrochlorothiazide by his family physician 3 weeks ago. Should I answer each one as we're going, or try to, fathom what the differentials are, or should we read all three versions first?
I think they are similar. I think they are similar scenarios, just similar scenarios that come in different patterns, but I think it's still pointing towards the same.
Okay, fine. So version 2 says a middle-aged woman with recurrent pain in her toes and digits. She had fever and flank pain. This is a bit different from version 1. But version 3 says a young man, 40 years, who takes alcohol and presented with pain and swellings of the toe. So versions 1 and 3, if we look at the scenario, I'm not too sure if the version 2 fits in with these others, but we look at scenario, that swelling and pain of the big toe is almost, should I say pathognomonic of acute gout flare, the so-called podagra. So there's swelling of the first metatarsophalangeal joint of the big toe, and this is sometimes the first presentation of gout in a person who may not even be known prior to have hyperuricemia, and it's called podagra. So that's a giveaway. Swelling of the big toe in a person with risk factors for version 1, hypertension. So he likely has other metabolic issues, probably including hyperuricemia, and then he was placed on a thiazide diuretic. They're notorious for thiazide and even loop diuretics could precipitate an attack of gout presenting with podagra. Then the version 3 as well, alcohol is also a risk factor. So we have a 40-year-old who takes alcohol. In fact, frequently after an alcohol binge, they could have podagra, so pain and swelling of the big toe. So that is the main number 1 differential. For this version 2, we're told middle-aged woman, recurrent pain in her toes and digits. She had fever and flank pain. For this patient, I am not sure that acute attack of gout would be the best differential. She's middle-aged. She had fever and flank pain. Maybe she had some infection. I don't know. The small joints of the hands, toes and digits. So probably both toes and digits. We're not told if it's symmetrical or otherwise, but I think for her, I might pick rheumatoid arthritis first as a first differential. But other possibilities, so what are the differentials for the ones with acute gout flare? It's a monoarticular presentation, we're told, right big toe, although it is less. Okay, so the second differential will be the other crystal arthropathy, that's CPPD, calcium pyrophosphate. Then septic arthritis is usually a monoarticular, usually present with a monoarticular affectation, but the toe is not the most common site. Then osteoarthritis as well, especially for this lady in version 2, we can have osteoarthritis of the hands, and the digits. So those are my differentials. We could add other ones, structures surrounding the joints, like enthesitis and other. Unfortunately, I'll need to sign off in a few minutes because I can't be late for the other presentation. So what is your most likely diagnosis for versions 1 and 2? I'll pick gout, acute flare of gouty arthritis. For the lady, probably RA or hand OA, but our rheumatologist can help give better, if there's better differential. So what other questions will you like to ask? So whether it's the first time, and to fully characterize arthritis, they said pain and swelling. Is there limitation of movement? Is there a pattern to it? Have they recognized triggers? So for like the ones with gout, like I said, alcohol binge could be a trigger, use of diuretics. Okay, then other joint affectations, of course. So is it only monoarticular? Are there other joint affectations? Are they large or small joints? Are they symmetrical or asymmetrical? how frequently do they have flares if they have them? Especially for the lady, do we want to rule out a more like other connective tissue issues? So would ask for hair loss, ulcers, should there be? Then of course, how whatever this presentation has affected their quality of life, medications they have taken for it. So that's what I can say for now. How will you investigate the patient? That's question D. We would want to do, of course, serum uric acid, but also serum urea electrolyte and creatinine. High renal impairment can give hyperuricemia. Hyperuricemia can give renal impairment. We might do inflammatory markers. Yeah, full metabolic workup actually for those with that gout, full metabolic workup, including lipids, and because gout or hyperuricemia can frequently coexist with other components of the metabolic syndrome, then we might want to investigate the joint with imaging. Yes, with imaging, and we might do more specific investigations depending on what else depending on what the patient might have. I'll be leaving in 2 minutes. What are the complications? Okay. Anybody with crystal arthropathy can have secondary osteoarthritis of that joint. Then for hyperuricemia, of course, there are other complications, like we mentioned, renal impairment. They can have gouty tophi, even though this is probably more a presentation than a complication. They can have deformities of the joint with impairment of function, like long-standing, they can have deformities. So, of course, those with gouty arthritis, thank you. Someone has mentioned nephrolithiasis. Okay, I don't know if for version 2 nephrolithiasis, but uric acid stones can form. That can be a complication. What else? Yes, we mentioned joint deformities. And I might need to stop at this question and have the others because I need to log off and log into my unit presentation if the class admin permits.
Okay, thank you, Dr. Luque. Wonderful.
Thank you. I would have loved to hear the remaining contributions, but I'll listen to the recording.
Okay. All right,
Bye,
thank you.
Thank you.
Someone will continue from where she stopped. Dr. Hello, yeah. Dr. Chineme, are you saying something?
Yes, yes. Let me
Okay.
just
Okay.
But in addition to the investigations, we can do retrospective, and then we can then popularize it to actually make a diagnosis of gout if we find sodium urate crystals that actually
Dr.
need
Chineme,
shape.
your voice is far away, so can you, hello?
Okay. Sorry, can you hear me better?
Okay, yes, better. Yeah.
Okay, so I'm adding to the diagnostic work. Added to what Dr. Ruka said, we can also do ultrasynthesis, okay, and then send for polarized light studies where we'll find monosodium urate crystals that are needle shaped and negative bifringent if we're thinking of gout. Also, pseudo gout is a differential where we'll find the calcium phosphate crystals that are positive bifringent. And we can do the serum uric acid levels. And then, of course, we know that this is not diagnostic of gout because you can have a high uric acid levels. It doesn't really translate to gout. And you can have a normal uric acid level, you can still have gout. So uric acid is not diagnostic of gout, but rather the actual synthesis with synovial fluid analysis. And we can also do 24 hours uric acid excretion. We can do imaging, like she said, and then we can send for white blood cells just to rule out septic arthritis. We can also do an ECR, uric kidney function test, like she said. Okay, and then also to add to that, the treatment for acute gout is actually we can do the prophylaxis to prevent the acute gout, and then we can do the actual treatment of the acute gout when it occurs, and then we can also tend to lower the excessive urate to prevent flares in acute gout. So generally, the treat to target is to reduce the serum uric acid levels to less than 6 milligrams per DL, to less than 5 milligrams if the patient has severe gout. If the patient has tophaceous gout, you want to reduce to less than 5 milligrams. Then we can, in the acute phase, we can use the goal is actually to relieve pain and inflammation. So we can use NSAIDs, we can use corticosteroids, then colchicine also can be used. Then the new one has also been shown to help with acute gout. So generally, even when it's used being the drug of choice, we should indomethacin is what is preferred, but we should avoid aspirin because it increases their by altering the uric acid level. So whatever alters the uric acid levels will lead to more flare. So even if the patient was on medication that could alter the uric acid levels, it's not very good to introduce it in the acute period because it would increase the flare. So this was what can be used in the acute period. Of course, colchicine, like we know, can be used, especially in the acute it helps to relieve symptoms. And then also after the
Dr.
treatment,
Chineme, can you make your audio smooth? It's like high and low volume. I don't know why.
oh, sorry, I don't know. I don't know what to do. I don't know. Is it better? Hello?
Yes, a bit. Maybe when you continue speaking, we'll
Maybe because of
accept
where
that.
I am. I don't know. I'm at work, so I don't know. Okay, sorry. So what I'm just saying is that for the active treatment of gout, NSAIDs, corticosteroids, colchicine, and anakinra, that's the interleukin 1 can be used. In the use of NSAIDs, indomethacin is preferred, and then you avoid aspirin when you use and don't introduce anything that will alter the uric acid levels because it can lead to increased flare and gout, more acute attacks. So for the prophylaxis, you can use the low dose NSAIDs for at least 6 months. You can also use the urate lowering therapy like xanthine oxidase inhibitors like the Purino. Then, of course, we'll remember the side effects of Purino. We can also do febuxostat. Use of febuxostat too can be used for prophylactic measures. Then uricosuric agents like probenecid can be used, and then the non-recombinant urate oxidase inhibitors like the uricase, rasburicase, think that pegloticase is part of it, can also be used for the prophylactic treatment. I think that's all I want to add. Thank you.
All right. Thank you, Dr. Chineme. Any other contributions, please? Sorry. Dr. Chineme, did you answer the other questions?
No, she didn't. I'm asking if it's possible for her to complete the question.
Okay. So I didn't see the other questions. Okay, so what are the complications? We have mentioned them already. So they can have deformities, they can have renal failure, they can have cardiovascular complications from the hyperuricemia. Then short and long-term management, we have mentioned that that's the treatment of the acute phase and then the prophylaxis for the long-term management. Would you want to give allopurinol now? Explain why. Just like I said, no, because allopurinol actually tends to alter the uric acid level. So if you introduce allopurinol at this time, will alter the uric acid level and lead to increased flare or gout. So it shouldn't be introduced in acute gout. Rather, you do the treatment for acute gout, and then later, when the patient is out of that acute phase, you can then introduce allopurinol. So the answer there is no. Then, how do you distinguish between acute and chronic gout? So I think basically for acute and chronic gout is based on their presentation, their clinical presentation, the duration the patient has had gout for. And in acute gout, the patient may come with flares, he may have pain, swelling, redness, just like in the scenario painted, the patient that had podagra and all of that. Then in chronic gout, usually they may come with deformities. Even to partial gout is also a sign of chronicity because most times it's over 5 to 10 years before you have the profile. It also depends on how high the uric acid levels are also. So these are the ones I can remember for the differences. Then what are the other side effects of hydrochlorothiazide? So for hydrochlorothiazide, we know they can actually give a risk of diabetes, so they lead to hyperglycemia. Then hydrochlorothiazide also they lead to hyperlipidemia, and then they lead to increased calcium in the hypercalcemia. Then what was that thing? Okay, so I think that's the one I can remember right now for HCTs. Thank you.
Okay, thank you. Thank you, Dr. Chineme. Very wonderful attempt. Any other contributions, please? Okay. Dr. Fiisi, thank you so much. Chronic gout also has tophi, observations, and CKD from hyperuricemia. Any of them? Any other contribution, please?
What that version 2 is not thought out very well. That version 2.
Okay.
If somebody can help us.
Version 2.
And can it be nephrocalcinosis or what? But I don't know.
Please, can you scroll up so that people can see the question again? Who's sharing for us? Can you scroll to version 2? Okay, I think it. Looks like someone that has a stone, maybe a nephrolithiasis, or that is complicated with a UTI.
No, can you hear me, Dr. Fa?
Okay.
Yeah, I think we've already mentioned some of the differentials. Okay, so like in this version 2, the patient could have septic arthritis. Okay, maybe through hematogenous spread. Okay, maybe there is background UTI. You can even have reactive arthritis. What's it called? It is irritable symptom or something like that. Okay, so reactive arthritis is also possible. Okay? So, but even gouty arthritis too can come with fever. It's just the flank pain that is kind of confounding. Okay, so
What,
I think those are
what,
yes. Go ahead.
what sir, can it be nephrocalcinosis?
Nephrocalcinosis is a big diagnosis, and usually on its own, it usually comes with something else. Okay, and it's more of, should I say, histological diagnosis than a clinical diagnosis. Okay, so nephrolithiasis is even better. You can say
Okay.
nephrolithiasis is complicated by urinary tract infection. That's fine too.
Okay.
Thank
you. Thank you, sir.
Yeah.
Very good, sir.
Yes, yes.
I
Yeah,
think let me
okay.
just add my voice to that question too. I think it's nephrolithiasis. It's not nephrolithiasis. It's one complication of gout too. So I think they're
Yeah.
just trying to create different scenarios of gout, how they present. And so I think that is the nephrolithiasis. I don't know.
You are right.
I think that's that.
Likely.
Dr. Atta, are we done?
Yes, we've answered. We've actually answered. Attempted the question. Yeah.
So
the question.
we've proven to you that the class is most people are exam ready. So I think we see we've answered the questions and we've achieved 3 questions today. Since the exam is next week Wednesday, most likely people will be traveling from this weekend. So Chief Remy Goods, I don't know if you have any final talk on the question before I do final. Chief Remy Goods, Chief Chitu, any final talk before I conclude?
Okay. Thank you, Dr. Christabel. I think I must say I'm proud of the people that came to class. So it's obvious that if people that are not serious or do not take us seriously, we don't need them. The people that came to class are serious people, and it's obvious and it's evident that they are ready and they are getting ready, they are prepared. Okay, so the way we answer these questions actually made me happy because it's obvious that these are people that are vibrating and are ready to answer questions. They are ready to face the examiners. Okay, so I was really proud of the class. But I must say a very big thank you to Taiwo. I practically threatened him yesterday and he has delivered. So I'm really very happy with him. And you see the way he delivered, very beautiful presentation. Is that